Good morning, everyone, and welcome to Massachusetts General Hospital Grand Rounds. It gives me great pleasure to introduce today's speaker, Dr. Jonathan Rosand, who will be speaking about preserving brain health, a vision for cerebrovascular health. An internationally renowned scientist, clinician, educator, and visionary leader, Jonathan has created a legacy of multidisciplinary teams that are successfully tackling some of the most pressing challenges in brain disease. His research program, launched nearly 20 years ago, has grown into the Cerebrovascular Health Research Program, led with doctors Christopher Anderson and Alessandro Biffi. His lab has been a leading contributor to high-throughput genome-wide association and sequencing studies in stroke and related traits. To accelerate genetic discoveries, Jonathan founded the International Stroke Genetics Consortium in 2007 to bring together the world's preeminent stroke investigators and launched the NIH-funded Cerebrovascular Disease Knowledge Portal to share data widely. Jonathan has trained a generation of national leaders in neurocritical care, stroke, and clinical investigation. He served as program director for Harvard's clinical training programs in stroke and neurocritical care and is PI of the NIH training program, Recovery and Restoration of CNS Health and Function After Injury. His lab has been the training ground for outstanding investigators who have gone on to establish their own independent research programs at top academic institutions in the US and abroad. Since 2012, Jonathan has served as director and now faculty for the ANA NINDS Career Development course for K awardees. After founding Mass General's Division of Neurocritical Care and building it into the nation's top program, Jonathan stepped down to establish the McCance Center with doctors Rudy Tanzi and Greg Friccioni. Without further ado, I give you Dr. Jonathan Rosand.
Jonathan, to another. Thank you very much for that very generous introduction, and thank you to the Chief Residents for inviting me today. I'm going to, first of all, for those of you who are not in attendance, you're missing mimosas and a gourmet breakfast. So, and you'll be delighted by how comfortable the chairs are in the redone. But it's lovely to be back in the Ether Dome. So we'll see if we can get this going. Oh yeah, this has to be one of the coolest rooms in all of Boston. So I've changed the title a little bit because what I'm going to focus on is trajectories a little bit beyond cerebrovascular disease. And part of the goal of this talk is to explain how a neurointensivist ended up in brain health. So, got this going. Okay. So, when I started off as a neurointensivist about 20 years, a little over 20 years ago, one of the things that drew me to the neuro ICU was that you could work in a large team rapidly to take care of patients who were in desperate need of help. And our focus was then, as it is now, to prevent further injury, recover lost function, improve lifelong trajectory for people who are injured, and we're supported by a high ratio of providers, probably the highest ratio you'll ever get for neurologic disease, and an extraordinary multidisciplinary team. Another special thing about the ICU is you focus on patients and families, and you're surrounded by the latest technology. And the way hospital budgets are set up is there is a continuous opportunity to invest in new technology. Let's look at what primary brain care is. You might call it outpatient brain care or brain care in the outpatient setting, whether it be in neurology, psychiatry, or primary care. The goals are to preserve brain function, promote brain function, improve lifelong trajectories, and prevent brain disease. So not that different. The only difference really is that you don't have an acute injury necessarily to deal with. So the point I will make is that the neurocritical care unit is a perfect model for moving out into the outpatient setting. So we're going to focus on trajectories, and this is going to be a theme of the talk, and what we can do to improve them as we figure out how to use this. Carol, I think. Okay, good. Right. And I'm going to focus on the disease in the beginning, to which I've devoted most of my career. And it's really quite a pleasure actually to have Steve Greenberg here, who got me started. And these are the diseases of the cerebral small vessels. You have on the left a nice cartoon enlarging them. All neurologists will recognize them. These are the penetrators here in the cortical subcortical junction or up into the deep gray matter structures. And these vessels with age very commonly become, the muscular lining becomes replaced by proteinaceous substances, and the two most common pathologies are amyloid angiopathy and arteriolosclerosis. And these small vessel diseases are probably the major threat to brain health as we age, because not only do they have so many different manifestations, from hemorrhagic stroke to ischemic stroke, subclinical stroke, gait disorders, dementia, and depression, but they're also exceedingly common. And so if you just use the MRI appearance and you ask the question, how commonly do you find MRI manifestations of small vessel disease as we age, you go from close to 10% of the population ages 50 to 59 to close to 3/4 of the population over the age of 80. So this is a real challenge, and it's an opportunity to, if we can tackle small vessel disease, we can have a dramatic impact on the aging process. So when I got started, our focus really was on what happens when these vessels rupture. And we were lucky to have access to the latest at the time, CT perfusion imaging, and we were asking questions about what happened to the flow of the blood around the hematoma as it expanded. We started to understand the time course of bleeding. So this is the same patient here whose hemorrhage expanded while in the emergency department after he presented to this volume here. And then we began to look at the different patterns of contrast extravasation. And one of the real privileges has been to work with a series of extraordinary fellows, now faculty, now very distinguished faculty. And the work that we started to describe the CTA spot sign, which is now discussed on rounds routinely, was led by Josh Goldstein, now professor of emergency medicine here, and carried out by a series of investigators whom we jointly mentored, the latest being Andrea Moratti, whose work you can read in the latest issue of the International Journal of Stroke. We began to become focused on outcomes early on, and in conjunction with Natalia Rost, who is now the chief of our stroke service, developed the first scores for predicting what the likelihood might be of functional recovery for patients. So the big question at the time was, how can we help counsel families when their loved ones have been afflicted by a hemorrhage and the patient can't communicate for themselves? How do we begin to think about what the likelihood of a functional recovery might be? At the time, the only prediction tools focused on survival, and that really wasn't the question that our patients' families were asking us. So we developed the FUNC score as a way of answering the question, what's the likelihood of recovering functional independence after sustaining a big cerebral hemorrhage? And that's led to a succession of improvements over the years, so that now we are much better in the ICU at advising patients and families about functional recovery. And I just want to call out the latest here from a recent graduate of our program, David Fisher. I encourage you to look it up in the latest issue of Nature Reviews Neurology. David has come up with what I think is the most compelling framework for discussing prognostication with families that I've seen in many years. David is now an assistant professor at the University of Pennsylvania. So as we began to focus more and more on the trajectory, months out now from the ICU, we were stimulated initially by a fellow, now the chief of neurocritical care at UNC, David Wang, to begin asking questions about the role of PTS, anxiety, and depression in these outcomes. And we were fortunate to make the connection with a very talented psychologist, Anna Maria Brancionu, who developed a program for not only understanding the risks of anxiety, depression, and post-traumatic stress in these survivors and their caregivers, but also an intervention to begin to try and affect primary prevention. And sure enough, her design, which is a resiliency enhancement intervention, it's non-pharmacologic, it's all about life skills. In preliminary analyses published 2 years ago, showed that if you expose patients and caregivers, so the key is you've got to give the treatment, the training to the diet, you can see that at baseline, controls and those who received the intervention had roughly the same scores on measures of post-traumatic stress. But at 12 weeks, there was a substantial reduction for those who had received the intervention in the ICU. So this really was the first demonstration of primary prevention in the ICU, and has gone on to become quite a big program under Dr. Branciono's direction. So now I'm going to turn to really the focus of the rest of this talk, which is thinking about years out. And the graph you see here is a work initiated by Steve Greenberg before in the 20th century, but the very end of the 20th century. And now, led by many now senior folks in the department, and particularly Alessandro Biffi, who's done a lot of the work here. And the work has been to characterize what happens to survivors of hemorrhage once they've made it out of the hospital. And so here what you have is a graph. Time equals 0 is when an individual has their hemorrhage. The red line represents those survivors who are Black and Hispanic. The orange line, those who are white. The yellow line represents a cohort of individuals who have cerebral small vessel disease as detected with an MRI. And the dotted green line is our best estimate for the US population. So what are we estimating in this case? Well, deterioration in brain health is defined as a new stroke, a new brain hemorrhage, the development of new cognitive decline or depression. And what you can see, so these individuals, they're recovering to becoming fully independent, but their risk of having deterioration is substantial. So for Black and Hispanic survivors, nearly 50% of those individuals will have suffered substantial deterioration of brain health by year 5. The figure is slightly lower for white ICH survivors, substantially lower for individuals who've never had an ICH, and even lower than that for the average general population in the US. The point being here that intracerebral hemorrhage is itself a marker for a severe and particularly aggressive form of cerebral small vessel disease, but there's no question that cerebral small vessel disease marches forward regardless of how severe it is. So our focus then is how can we change the life course, the trajectory of these patients? So what have we done so far? Well, we've tried to do the very best science to figure out what is the biology of what's going on. So I'm going to quickly go through, folks who are interested can read further. So we've assembled a number of teams to discover the mechanisms and treatments. The Cerebrovascular Health Research Program looks at epidemiology, imaging, genetics. This is our recent award from the Buer Foundation, the American Heart Association, where we've been given a series of, we've given funding for what's called a program project, for our training program, and a clinical a basic science and a population science research project to all focus on what's going on, why are these patients progressing? And this is just I thought this was helpful to see how widely collaborative the group of investigators on this program project is. And again, just to highlight how much this is a work of a community. And then finally, the International Stroke Genetics Consortium, which we launched in 2007 and really has been the driver for all the genetic discoveries, not just for hemorrhagic stroke risk, hemorrhagic stroke progression, but also ischemic stroke risk. And I point to the latest large-scale analysis that's about to be published in Nature, led by our colleagues in Munich and Bordeaux. The research that was carried out by that group, so important, but it's not going to get to the bedside for many years. And the problem is our patients can't wait, and frankly, neither can we. So what can we do right now? And the urgency is profound. If you just think about the figures, the Alzheimer's population is predicted to quadruple by 2050. And if you just delay the onset of Alzheimer's, not even prevent it, or dementia, that is, the impact on the economy is massive. The same is true for stroke and for depression. So the bottom line is we already know what the future will look like if we continue to do the same things we're doing now. We have to change that future if we're to have an impact on our patients' lives. So that's what prompted the launch of the McCance Center. Our goal was really to figure out how to respond to this crisis, rapidly growing crisis of non-communicable brain diseases. And our goal was really to bring together all the disciplines that would be needed to prevent brain disease, promote brain care right now, while paving the way for future preventive treatments. And we were very lucky to be joined by an extraordinary philanthropist, Henry McCance, and his family to launch the McCance Center for Brain Health. And in bringing together the three co-directors, we represented very complementary research and clinical expertise across neurodegeneration, cerebral vascular disease, acute neurologic care, outpatient neurologic care, psychiatry, and crucially integrative medicine, mind-body medicine, with Greg Friccione being the director of the Benson Henry Institute. We've been ably supported by a very wise and committed advisory board, and we have a unique oversight structure jointly by the chiefs of neurology and the chief of psychiatry, as well as the vice president for neurosciences. And I think this oversight has been incredibly generous and has done a lot of clearing the way for us in ways that without those ways, we wouldn't have been able to be successful. So this slide is just designed to give you an overview of the activities of the center. I'm only going to focus on a few of them. We describe our goals as the 3 I's: identify and characterize the indicators of brain health, discover and develop the interventions that will prevent brain disease and improve brain function, and catalyze a borderless community of knowledge and tools for integrating these indicators and interventions into primary care. Our focus is primary care because this is where preventing brain disease has to be localized. This is not, frankly, the domain of neurologists and psychiatrists. However, we all have the opportunity to contribute as we see patients who already have brain disease. So we have platforms and initiatives, the Brain Care Score, I'll go into that today, data science platform, the Human Sleep Project, led by Brandon Westover, platform for discovery and interventions for prevention, led by Rudy Tanzi, social determinants of health, our clinic, led by Zaina Shamali, a COVID-19 program also led by Zaina, and a training program that we are developing for launch soon. And we've devoted substantial effort to funding other investigators to essentially build the intellectual community around brain health and primary prevention. These are the features that we identify as unique among the sort of plethora of brain health centers, many for-profit brain health companies. We really are focused on the science, following the science as our lead on how we intervene, and also a focus very much on health equity, because the for-profit environment is not a place where health equity can be served in particular. So we'll have to have another opportunity here from Rudy to talk about his vision, but we've been very lucky to build out at the center now a platform that's going to do clinical trials for repurposing, can't see the titles, repurposing of already approved drugs for other indications and natural products that target Alzheimer's neuropathology long before symptoms occur. We've just recruited Gene Bowman to lead our clinical trials program. He's going to work very closely with the Integrated Brain Center and the NCRI to essentially launch a platform for prevention trials focused on biomarker outcomes. And so what's the goal? The goal is to do for brain disease what's been achieved for heart disease. And what you see on this graph is the dramatic reduction in deaths from cardiovascular disease from 1969 to 2020. Much of that driven by the integration of primary prevention into primary care. So you think about the lipid panel and the prescription of statins as just one facet of that. For colorectal cancer, screening has led to a substantial reduction in mortality. And this has been documented in about 6 clinical trials. Brain disease now as a target of prevention is really mainstream. And we were thrilled after the launch of the McCann Center when the Lancet Commission published in 2020 its report on opportunities for dementia prevention and intervention. The estimate of this group was that roughly 40% of all dementia cases could be attributed to modifiable risk factors. Shortly thereafter, the American Heart Association published, in conjunction with the American Academy of Neurology, a primary care agenda for brain health. And within a month, we had the release of the 3 National Academies report on the fundamental necessity of high-quality primary care for the health of the country. So there's attention being devoted to all of the issues that are clearly fundamental to our being successful in our mission. And just next month, the WHO is going to announce its report on optimizing brain health across the life course, and anybody who would like to attend, you can Google it, or there's a QR code there for registration. So now we're going to get to the question that really motivated the launch of our clinic and continues to motivate a lot of the work that Zaina leads as the medical director of the McCance Clinic, which is patients often who are caretakers of individuals with brain disease or have had a relative develop brain disease are asking us, what can I do to take care of my brain today? And usually it's, can I play these games or should I buy this program? And the good news is there's lots you can do. The bad news is it's very hard to often distinguish what's scientifically valid from what's well advertised. Another challenge is the term brain health. This is one that was really exposed when a couple of very high-profile books on brain health were making the rounds in the last 2 years. And on the interview circuit, there was the questioning was repeatedly about, is my brain healthy or not? And the problem is, number one, there is no standard definition of brain health. Number two, what happens when you've had a stroke? Does that mean that you don't have brain health anymore? Or when you've had one episode of depression? So it's really a problematic term because if you think of how common brain diseases are, there's the risk that we automatically label a third of the population as not having brain health. And so that risks adding even further stigma to brain disease. And as many of you know, brain diseases, one of the challenges with treating brain diseases is the stigma that's associated with them, both for patients and families. So we're trying to get away from the term brain health for all sorts of reasons and move to the term of brain care. Brain care can be available to anybody, and fundamentally it confers agency. And we think that's the key to overcoming this hump of all of us having the knowledge that modifying these risk factors will reduce your risk of developing disease, will improve your trajectory, and yet it's quite difficult for each of us in this room or on the video conference, as well as our patients, to actually act on that knowledge. So we think that shifting the conversation to brain care is going to be fundamental to getting over that hump so that we can all act on that knowledge. So we've developed this tool called the Brain Care Score, based on the principles that whatever tools we integrate into the bedside or the office, whether it be in primary care or specialty care, must be simple. They must motivate. They must be designed to motivate patients and providers to engage in brain care. They must act to reduce stigma rather than increase it. Stigma is a huge barrier to motivation. They must have very high face validity because none of us practitioners have any extra time in the office. So we better be convinced that whatever we add to our workload, whatever we're asking of our patients is worth taking on. And they must have very high scientific validity, which means you have to have evidence over time supporting their use. And then finally, they have to be distinguishable in a straightforward way from the vast for-profit marketplace of brain care, brain health items. So I'm going to take you through this score, which we developed over about 1.5 to 2 years of testing in the McCance clinic. Nothing is going to surprise you about it. So it's made up of 3 components. The first is physical, blood pressure, blood sugar, cholesterol, BMI. As you improve your score, as you improve your health, so no, that's not the right, as you improve your care, your score goes up, and that's key. The second component are lifestyle choices, diet, alcohol use, smoking, aerobic activities, and sleep. And the third component is about social and emotional stress, social relationships, and meaning in life. The point assignments are derived from our best estimates. They are without question they are not as precise as we would like them to be. And so this is simply a matter of acquiring data over time to continually refine the points. Remember, this is a motivational tool. So the point system is ultimately going to be set up to be both as highly motivating as possible and as scientifically valid as possible. So we've begun to examine the predictive validity of the brain care score. Our first analysis was in the regards cohort. This is a longitudinal cohort of about 30,000 community-dwelling Americans funded by the NIH, largely the National Institute of Neurologic Disorders and Stroke, an oversampling of individuals in what's called the stroke belt here. This is the region of the country with the highest risk of stroke. And so what we did is we took all those individuals in regards from whose records we could reconstruct a brain care score. And those individuals had to have not had a stroke yet, not had an episode of depression, and not had any evidence of cognitive decline. So we were able to come up with close to 13,000 individuals. The mean age was 62.5. And the outcomes of interest were depression, cognitive decline, and stroke. And we looked for simplicity at first at the combined outcome of stroke and cognitive decline. And what we found was that the brain care score was associated with reduced risk of the combined outcome of stroke and cognitive decline across all age groups. And what you can see here, this is the individual's age this is the decade, I'm sorry, that's not quite right. This is the age over, this is age 45 to 55, this is 55 to 65, and this is age 75 to 85. So I apologize for that. And what you can see here is that no matter at what age that brain care score is calculated, it's associated with a reduction in risk over time. The slope of the curve is greater the older you get. So it means that it's never too late to improve your brain care score and have an impact, or the interpretation is that it's never too late. This is all retrospective data. We haven't actually been able to ask the question, does changing your brain care score, improving it, reduce your risk of subsequent dementia or stroke? But this is the first step in establishing validity. These results shouldn't be a surprise. The brain care score, in fact, shares many entries with the American Heart Association's Life Simple 7, now just modified to Life's Essential 8 with the addition of sleep. And I just want to highlight here the way the American Heart Association has chosen to discuss and to introduce both Life Simple 7 and Life's Essential 8. They talk about ideal cardiovascular health and the definition of ideal health. And if you recall what I was highlighting with regard to brain health, we would argue that this is one of the reasons why neither of these tools, well, Life's Essential 8 has only just been published, but Life Simple 7 has not been widely adopted. And there isn't a lot of data showing that adopting it actually leads to a reduction in risk. So there's a lot of work for us to be done as a community in getting this knowledge out into our practice and actually leveraging it to change trajectories for patients. So the brain care score is in use now in the McCance Clinic. We've been using it now for our patients with really results that I'm very proud of. Our patients can embrace it. Our practitioners embrace it. We have a smart phrase that we use. We all realize that the patients who come to the McCance Center are those who are highly motivated. So this is hardly a representative sample. And for that reason, we're rolling it out and getting it out of the McCance Center into other practices as quickly as we can. There's a digital version. There's now a version in Spanish. And all of this on the McCance Center website is available and downloadable. And patients actually can now compute their own brain care scores on the website, although they will need a few lab values. We've had a wonderful partnership with Jacob Mirsky at MGH Revere, who's developed a large program of virtual group care. And so led by Amy Newhouse in McCance Center, who is a double boarded in internal medicine and psychiatry, we've developed a virtual group program in brain care that has been quite successful. And the goal is to really expand the use of the score, and in the process, identify what it takes for patients and providers to accept it. Acceptability is really a challenge for us. And balancing the fact that we are rolling a score out where the scientific validity is not all in place. And this is something that we're not used to doing as a community. We're used to really requiring that the data really support some intervention in the clinic before we intervene, before we put effort behind it, and often before payers will reimburse for it. And our argument is, we think that what the brain care score contains is so non-controversial, so acceptable, that it's worth maybe suspending that skepticism a little bit and starting to tackle the issues of implementation, which I'll come to in a second. Along those lines, I want to emphasize that there are many other components of what one calls brain care that could be part of the score. We had a long discussion about meditation, for example. As you know, there are many in this community here at Mass General who are quite supportive of meditation as an intervention to improve brain health and reduce risk of neurodegenerative disease. But we concluded that that meditation itself would raise too many skeptics' concerns. And so we really wanted to make this as unobjectionable as possible. I also want to highlight that we've had a terrific collaboration with the University of Alabama, led by Ron Lazar, where his team has brought the brain care score into the family practice group at UAB, into the waiting rooms there. And we'll come back to the Yale group and the RFA shortly. So what is our plan for implementation? And this is the part where I'm going to ask for you guys to consider stepping up. So we've got a fabulous implementation team led by Amy Newhouse. Lydia Mora is the implementation expert who has joined us. Zaina and then Courtney Nunley, who has a vast experience in hospital marketing. And we've got a strategy of rolling it out. I'm going to focus just not on the external for now, but on the neurosciences and primary care. In the neurosciences, we've just begun to work with the London 6 nurses, and we're hoping to engage the London 7-8 nurses for a program of integrating brain care into nursing care of patients and families. And then we've begun to work led by Zaina with different neurology outpatient practices, hoping that there will be champions in the subspecialties who would be interested in bringing the brain care score in to those practices. We have found, so I also see individuals with stroke recovering from the ICU, that the family members of these patients are intensely interested in the brain care score when they hear about it. In the world of primary care, Jacob Mirsky has been a lead partner here, and those in gray are individuals with whom we're having conversations to figure out how best to set up the brain care score as part of their workflow. It's so vital that the workflow not be disrupted. We're all burnt out to some degree in the world of outpatient care, particularly at Mass General, and no group more so than those in primary care. So we have to work very carefully with them. So if you're interested, please reach out to our team. We have our QR code here. You can go to our website. Our team is going to be after you anyway, so don't worry. I do want to highlight one thing, and I think this is really crucial, both for how we implement brain care and also how individual physicians think about implementing it in their patient populations. We created a score designed to be as appealing and as unobjectionable to as many people as possible. But there is no reason why, for example, in the MS program, there might not be a score that includes maybe some or all of this, and also components specific to multiple sclerosis. The concept of brain care, the embrace of brain care, is what we think is the most important component to get out there. Where we have resources available to kind of think about what might be other, maybe unique components to a score in particular clinics. But all of that is open to discussion, and so we're eager to hear from you if this is something that would appeal. What is the next step? And I think this is one issue that we really have to work on. How does one hold the patient and the provider accountable in some way for progressively improving the score? We're investigating health coaching resources. The Revere, MGH Revere has those resources, so we're able to leverage those, but most practices don't. So this is something we think we can work out with each individual practice, and we certainly have developed a homegrown version in the McCance clinic. So now I want to turn to what I think is really our biggest challenge, which is we've known for decades that, for example, blood pressure control or exercise or diet can substantially reduce our risk of heart disease, which is, the leading killer. And yet we also know how hard it's been for our population, for ourselves, to incorporate particular health habits into our medical care. So what are we doing to tackle the barriers to implementing, let's just say, heart care or brain care? And I'm going to bring us back to the curves for these patients with intracerebral hemorrhage. This is flattening the curve, took on new meaning in the last 2 years, 3 years. But really, that's what we aim to do for these people. Imagine if we could flatten this curve by just a third. Imagine how we would transform the lives of these individuals. Imagine what we might be able to achieve for resolving this substantial healthcare disparity, which is represented by the gap between the red line here and the orange line here. So one way to do that would be to tackle blood pressure control. So it turns out that blood pressure control, we've learned over about 6-7 years of work, is the most potent predictor of progression of cerebral small vessel disease. Yet, even at Mass General Hospital, let alone at communities across the country and around the world, fewer than half of ICH survivors ever achieve adequate blood pressure control. So this presents a unique opportunity. Even a minor improvement in blood pressure control would prevent more than 20% of cases of stroke and dementia. So it's an extraordinary opportunity. All we have to do is have a small improvement overall in blood pressure control. Well, there have been a lot, there's no secret here. There have been a lot of studies looking at relatively sophisticated ways of engaging communities, engaging stroke survivors in blood pressure control to see if, in this case, this was a clinical trial led by Amy Tofigi, our colleague at the University of Southern California, whether a coordinated community and chronic care model could improve blood pressure control in stroke patients. And so what that means is these were individuals, care coordinators who were assigned to patients at discharge from the hospital and reached out to them regularly to work on their blood pressure control. So there were close to 500 individuals who were part of this clinical trial. And I'm going to cut to the chase. There was no benefit to this intervention, which is the same story for all these interventions after stroke. So we got to figure out why. So we were just waiting for the Notice of Grant Award, but to study this, we have developed the very first multi-center trial to ask the question, what are the barriers to engagement? Why is it that despite being offered sophisticated, accessible strategies for blood pressure control, why is it that patients nonetheless aren't able to achieve better blood pressure control? And we're very excited about this, this grant because it's going to allow us to ask that question as comprehensively as possible, looking not just at the social determinants of health, but looking as well at the clinical and biological factors. So this is the group that we brought together. These are the centers. They extend from the East Coast to Hawaii. And we're very fortunate in that we're already in the stages of adding on different aspects of brain care assessments to this cohort, so that ultimately this can become a laboratory for studying implementation in a very high-risk group for deterioration in brain health over time. Another thing we're doing is we've, as I hope is well known in this audience, we have announced a funding opportunity. The McCance Center is looking for applications, they're due at the end of this month, from investigators who want to collect preliminary data to understand understand barriers to implementation or develop implementation strategies for brain care and primary care. This is a national RFA. We're thrilled that we're receiving applications from around the country. And some of the opportunities are to examine strategies for engaging communities, particularly those impacted by healthcare disparities, the assembly of patient and community advisory committees, mechanisms for sustaining behavior change, figuring out how to establish sustained engagements by providers and patients, and very importantly, what strategies might be successful for integrating digital health and technologies in primary brain care. So to conclude, we think it's important that we begin to shift the conversation away from brain health to brain care, and that we shift the focus of brain care from the reactive, what we're so good at here in Mass General and peer institutions around the world. Patients come to us when they're symptomatic, to the combination of reactive and preventive. So every time we see a patient with disease, it's not only an opportunity to help them recover, but it's also an opportunity to introduce them to primary prevention or secondary prevention across the lifespan. We know that primary prevention works. We know it works in heart disease and cancer. So there's really no reason why it shouldn't work in brain disease, although we've got to figure out strategies for success. So what will success require? Team, science, implementation, team funding. The McCann Center exists solely because of visionary philanthropy. This is not work that has traditionally been funded by the NIH. It's not been traditionally funded longitudinally by foundations. And so we're very fortunate that we have committed philanthropists to support the vision. Certainly, we've been very fortunate as well in securing NIH funding, but that alone will not keep this project going. We have to combine scientific rigor with simplicity. This, for me, has been a great lesson of this work, that it's no longer sufficient to have the most elegant disease models to present the most rigorous science. We have to be able to translate that rigor, that approach, into patient-facing, patient-centered interventions and provider-centered interventions. So for me, this has been a wonderful learning experience. And then finally, engagement. And this is going to be a project that will require thousands of practitioners, hundreds of thousands of practitioners to embrace it for it to be successful. So I'll conclude with this. Yeah, we know that this is hard work, but if we don't start it now, if we don't do it now, we're just going to allow the tsunami to crush us. Right now, today, we think that up to 40% of dementias can be delayed or prevented, more than 50% of strokes probably, and roughly 38% of major depressive episodes. So this is the opportunity, and it's thrilling to be approached time and again by all these outstanding residents and fellows who are engaged with a mission that is really outside of what has been traditional neuroscience. So I'm very encouraged that we're going to have an impact, and I'm very encouraged by the ideas that are being brought forward by people who are so deeply connected with different patient populations. So I want to thank the team, and in particular acknowledge Greg and Rudy, who have been my partners through this and really have shaped every aspect of the vision and the work we do. And of course, the rest of the team really is, I'm representing them here. And our funders over the years, obviously we couldn't have done it without them. And thank you very much for your attention. So do I ask? Oh, yeah. So please, you can either put your questions, for those of you who are attending virtually, you can put your questions in the chat. And then I will kind of navigate between the chat and the live audience here, comfortable in the air conditioning with their mimosas. So I'm going to start with Dr. Greenberg.
Thanks very much. I may have to, I guess, repeat for the.
So you have to be succinct. I'll repeat.
I'll try. Anyway, really inspiring, especially the focus on buy-in and implementation, which we know we haven't been, so it's really inspiring. What struck me is not on the list of outcomes that people worry about the most is gait, and I just was curious to hear you speculate on it in that time before. That are the things that when people list what they're most scared of, along with losing cognition, is losing mobility, and ability that we depend on mobility so much for daily living. So I'm curious what the thought is on whether this approach can be extended to maintain gait health along with treatment.
Thank you for that, Steve. I'm going to repeat the question Dr. Greenberg has asked about whether we should be also thinking about gait as a focus for preserving brain health over time. This is a question that comes up a lot from patients, and as many of you are aware, fall risk is a huge concern in the geriatrics community, in the hospitalized patient population. So the answer is yes. Gait is absolutely a focus. The challenge is simplicity. So we have tried to really start simple in the beginning to engage the conversation for patients and providers. Gait and mobility is a preoccupation of a much wider ecosystem in general than neurology and psychiatry. And the assessment is a little more complicated. So we would like to take it on. We're looking for champions to take it on. It must be there. We simply haven't gotten there yet. But I think gait in particular, or mobility, how we understand mobility has to be part of the equation. The preventive task, U.S. preventive task forces, and I think that the general primary care community have embraced fall risk as a sort of the first step. I'm going to go back and forth. So we have one question from an anonymous attendee. Many brain health measures are the same for cardiovascular and oncologic health and prevention. Have you thought of how you can expand buy-in from these specialties? It might help in terms of resource sharing. So that's a really important point that I think I was remiss in not emphasizing. We have designed the Brain Care Score to be a one-stop shop so that you can take the Brain Care Score into your practice and you don't have to have a separate score for cardiovascular health and largely for cancer health or cancer care, cancer prevention. So the issue is exactly that we're trying to get expanded buy-in from primary care by telling them or convincing them that, number one, more of the population has had direct experience of a brain disease combined, ranging from depression to mental health to neurologic health, than cancer or heart disease. So we argue, unproven so far, that brain disease as a motivator is the best motivator if you want to have one motivator. Everybody can relate to their brains, and the Brain Care Score really does contain all of the essential components of life's essential 8 and of many of the lifestyle habits that are associated with reduced risk of colorectal cancer, lung cancer, and others. Marcelo.
Thanks, Sean. That is a beautiful effort and bringing teams together. Two quick questions. The first is, have you considered adding ongoing educational intellectual activities, reading, watching movies, learning new hobbies, new skills in your score, number one? And number two question is, what's the plan to add things that become relevant? So for instance, if research shows that drinking coffee prevents Parkinson's or dementia, how would your group envision expanding the score as practice?
Thank you for those questions. A key component of the question was, how do you integrate new knowledge about risk factors as it becomes as that knowledge becomes robust? And I would say our goal is to get in with the simplest score possible first, so that we embrace the concept of some sort of a motivational tool to encourage what we know for sure is going to help. I think the example of coffee, let's imagine a future where coffee prevents Parkinson's. I could understand whether the primary care community would be hesitant to automatically accept every new risk factor because it might become overwhelming. I think we have to study that. So our hope is that in the next 5 to 10 years, we'll actually ask that question from an implementation science perspective. We now have new knowledge. What's the best way to integrate this new knowledge into a tool that we hope is already being successfully used? So that we don't have any answers, but that clearly is a goal. I think one example for, let's say, the coffee and the Parkinson's, we have to think about what is the actual risk of Parkinson's for the population is relatively low as opposed to dementia. We also have to weigh that. Okay, we have another question. How do you plan on integrating this work into primary care? Well, thanks for the question. Yeah, we have, this is an evolving strategy. Right now, we are identifying champions in individual practices who are sufficiently enthusiastic to work with us to develop a work plan and to do some sort of an assessment where you have then an evaluation at the end of the assessment as to whether there has been acceptance of the brain care score by practitioners and patients. Scaling that up, I think, is the next stage, and we're open to ideas, and we're hoping to receive compelling applications for the request for the funding opportunity that we've just released that might address that question. Another question here. So we have, nice to see Jean Latour. Are we planning to change our center's name to the Center for Brain Care? Well, it's a very interesting question. Stay tuned. We have to figure out how best to serve the mission. Thank you. All right. If there are no more questions, then thank you for your attention.